Good evening. Namaskar, everyone. On behalf of President Dental Council of India, Dr. Devendu Majumdar, I feel privileged in extending a very hearty welcome to you all in today's session, the 13th DCI Continuing Dental Education webinar. At the outset, I want to convey my heartfelt gratitude and thanks to the President DCI for starting this knowledgeable series of webinars on such interesting and clinically relevant topics from one of the best academic institutions of the country, which are absolutely free for the participants. Being one of the most adorable, popular, and respectable teacher of the country and clinician par excellence, it was the vision and dream of Dr. Devendu Majumdar sir to give an opportunity to all undergraduate and postgraduate students as well as the dentists of the country to learn from the expertise of the best teachers and best clinicians of our country. From the core of my heart and on behalf of all academicians of our country, I applaud the efforts of DCI under the dynamic leadership of President Dr. Devendu Majumdar and Secretary Dr. Sabyasachi Saha for providing this learning platform to our students and fellow colleagues during these difficult times. I also extend my sincere appreciation to our dynamic Secretary Dr. Sabyasachi Saha, an ever-smiling and cool personality in galvanizing and activating his whole team in translating the vision of President DCI into reality. I shall especially mention in this regard the great contribution of Mr. Mukesh Kumar, the Deputy Secretary DCI, and Dr. Varinder Goyal, Professor and Chair, Department of Pediatric Dentistry, Guru Nanak Dev Dental College and Research Institute, Sunam, in the success of these webinars. The tremendous response with more than 20,000 attendees with rapidly increasing numbers in each webinar shows the popularity of these webinars, particularly in terms of their content and selection of topics and speakers. I remember during our childhood, we used to wait for the telecast of movies and Chitrahar on DD channels on Sundays. The same enthusiasm is visible for these webinars among the dental fraternity of our country. My dear friends, at one time, when almost all of us have stopped working due to lockdown, it was the DCI that gave us the courage to start the clinical practice with scientific evidence to work during COVID pandemic with proper personal protection and infection control practices through these webinars. I am of the strong opinion that we can only progress if we keep on working to improve the standards of our profession, following the ethical practice and serving the humanity, irrespective of whatever condition may arise. Now, before starting the session, I am directed to make the following announcements. The DCI webinars are free of cost for all attendees. At time of registration, complete and proper details must be furnished since the same will be captured for generating e-certificate and CD points. The certificate will be sent to attendees by email within 3 days of conclusions of each webinar who have attended the entire session of a webinar uninterrupted. Attendees may also download their certificates from webinar section of the DCI website. Now it's my privilege to announce the names of the 5 dental colleges with highest participation in the previous webinars. And these are Vishnu Dental College, Bhimavaram, Andhra Pradesh, Saraswati Sardar Patel Postgraduate Institute of Dental and Medical Sciences, Lucknow, Saraswati Dental College, Lucknow, Pananiya Mahavidyalaya, Institute of Dental Sciences and Research, Hyderabad, and St. Joseph Dental College, Elluru, Andhra Pradesh. We expect and appreciate the same support from other dental institutes in our future endeavor. Now, I take honor in introducing our today's speaker, Dr. R.S. Mohan Kumar. Dr. R.S. Mohan Kumar has done his master's in conservative dentistry and endodontics from Dr. MGR University. He is alumnus of Savisa Dental College and has done his post-graduation in the year 2004. He is certified fellow in implantology and has done his diploma in lasers. He is presently affiliated to Priyadarshini Dental College, Chennai, and is working as a professor in conservative dentistry. He is Joint Secretary of Indian Association of Conservative Dentistry and Endodontics, diplomate in Indian Board of Micro-Restorative and Endodontics IBMRE, and is also a board member in the IBMRE. He is Deputy Editor of the Journal of Conservative Dentistry. Dr. Mohan Kumar will be speaking on one of the most sought after topics, that is role of magnification in conservative dentistry and endodontics. Use of magnification has revolutionized the practice of restorative dentistry and non-surgical and surgical endodontics. More and more dentists are having are started having microscope, magnification devices, loops in their clinical practice. Besides being an important diagnostic tool for complex cases, the use of magnification has significantly improved the outcome of surgical and non-surgical endodontic treatment, as well as the quality of direct and indirect aesthetic restorations. When we talk of magnification, most of our presentations are either on fracture instrument retrieval or some complicated procedures. Dr. Mohan Kumar's presentation will be slightly different, and he will be speaking more on the it will be more clinically oriented. He'll be enlightening us with his dedicated clinical experience of more than 15 years in this field, more on the use of magnification in restorative dentistry and its use in routine practice, starting from what you see from class 1, class 2, class 3, up to class 6 cavities, complete to build up indirect restorations, including inlays, onlays, laminate, reattachment of fractures, besides use of magnification in routine endodontic practice, that is access cavity preparation, BMP, and obturation. So friends, colleagues, and my dear students, fasten your seatbelts and get ready for the 1-hour journey of this thrilling learning experience. Over to you, Dr. Mohan Kumar.
Thank you, Sanjay sir, for such a nice introduction. Good evening and welcome to all. Before starting my presentation, I would like to do a big salute to all the Avengers, meaning the doctors, the paramedical staffs, the politicians, the people, and who whatsoever stood tall, faced this COVID to tell a tale, and those who lost their life in it. With this, I start my presentation. Magnification in conservative dentistry and endodontics. Whenever we talk about magnification, the first question which is asked is it necessary? Dear friends, after this seminar, you will be in a right position to think whether it is necessary. Usually, necessity is the mother of all inventions. If we hadn't thought of a lot of things, we wouldn't have had any better things for us to do right now. And then, if I'm going to say A, Ford, your answer is going to be Apple. And who wondered Apple will be such a big industry right now? Likewise, if I'm going to say magnification, most of us equate magnification to endodontics. Me being an endodontist, sometimes feel bad that it is only used as an endodontic tool. But magnification has a greater role in most other forms of dentistry. For example, conservative dentistry is one of the most important parts where we try to save the tooth structure. And if you ask me, magnification, I would equate it to dentistry per se. Let's see how. What does that magnification do? There are a lot of advantages of magnification. To me, there are only 3 things which magnification does. 1, it helps me to diagnose. When I am able to diagnose properly, my treatment plan becomes strong. When my treatment plan is pretty strong and under magnification, I can execute my treatment plan to 100% precision. This is what magnification actually does. What are the types of magnification? Trust me, these are the only few slides in which you will have written matter, after which we really don't have anything to write about. There are 2 types of instruments which are actually used for magnification. One, the microscope. The other one is the loop. Microscope is an advanced version where you can document, you can see, you can adjust, you can do quite a lot of things. If you're a beginner, start with loops. There are loops which range from 8,000 to 1 lakh. It depends upon your pocket, what kind of loops you want and how much are you able to invest. But like I said, what are we looking at in magnification? In magnification, the main thing what you look at is something called as resolution. What is resolution? Resolution is nothing but to differentiate two objects which are lying close to one another. If you're going to use a loop, for restorative purposes, anything more than 3.5x is good enough for us to go ahead. For endodontic purpose, you will require a maximum magnification, in which case you will be forced to get a microscope. So what are the difference between a loop and a dental operating microscope? These are the common differences which you have. One is cheaper, the other one is expensive. One is portable. Loops are easy to learn, but microscopes have a steeper learning curve. But once you get used to it, there's no going back. Trust me. Level of magnification is between 2.5 to 6x, whereas with dental operating microscopes, you have from 3 to 30x. So this is the common difference between a loop and a dental operating microscope. Now, whatever pictures, whatever you're seeing today will be taken from a dental operating microscope. For example, most of the working range in a dental operating microscope ranges between 0.4 to 1.6. Beyond that, it becomes too much magnified where actually you can't work. So what does it help? Please see this video. And there is another misconception with magnification. The thing is, the moment I say magnification, every point which I'm using here is quite big. But what does magnification provides me is the advantage of me looking where I am doing the procedure. You see that? I am very, very clear where I'm touching the tooth surface, what am I removing, and how much am I removing. This is the most important factor in conservative dentistry. Let's push our luck now. Let's shift to another diamond point. This is TR62C, one of the commonest diamond points used by prosthodontists for preparation of tooth structure. Trust me, this is one big diamond point what you have there. But with that also, you can see me working as close to that lateral incisor, but at the same time not nicking it. That is what actually magnification does. It allows you to preserve as much tooth structure as possible. Why is it necessary? The reason is we all shifted from slow speed to high speed. When we started using high speed, we forgot to conserve tooth structure. Most of our evaluations were all done based upon the preparation of the tooth rather than saving the tooth structure. When you start using magnification, you will know what kind of dentine you are seeing. You will know how to excavate and what to leave and what not to leave. You will also see that we started a case like that and I finished it off like this. You will not know where it starts and where it ends. Most of us call it as aesthetic dentistry. This is what is aesthetic dentistry, which means your work should never be appreciated. If your work is appreciated, trust me, the work what you're doing is not good. What else can we do with magnification? You can see a pit and a fissure this close. Or when you prepare a cavity, you can see areas of cracks which you can avoid, areas of demineralizations. All these will determine the outcome of your restoration. Or cases like this, the first picture, what you see there is around 0.4x. Your decision on seeing it like this will be that I am going to leave the inlay as such and I'm going to work on the premolar. But when you take the same tooth under a little more magnification and then you see a cavity underneath the inlay, then your entire diagnosis and treatment plan changes, to which you will replace the existing restoration. At the same time, you will prepare a proper cavity on the premolar so that both of them can be restored at the same time. To me, this is what magnification is. Today, I will be talking on direct restorations, indirect restorations, and a bit on endo. When we talk about direct restorations, I'm going to stick on only to bonded restorations, which is what most of us practice routinely in our day-to-day practice. So what are the cavities which we commonly see? We can enlist it from class 1 to class 6. And then indirect, inlays, onlays, and veneers. Let's start with the basic class 1 cavity. A tiny cavity which doesn't require extension for prevention. All you have to do is to remove the existing decay over there. So your cavity preparation becomes as small as possible. At the same time, your restoration also becomes as neat as possible. Why? You remember the point which I told you, resolution. Resolution plays a very, very important role, which allows you to see the primary groove, the secondary groove, the tertiary architecture, everything which is present on the tooth surface. You really don't have to search anywhere. All you have to do is to join the dots. When you do that, you get a perfect, nice restorations. Sometimes we are not blessed to get that. A case like this, still a class 1, but imagine the surface architecture, quite complex. So usually in these cases, what I do is, we all know what's a stamp technique. Slight modification of that is you take that with a clear putty. Just take an impression of the tooth structure with a clear putty. Prepare the tooth, place composite on top of it, place your putty back, light cure it, remove it, and then light cure it. You will get the same anatomy what you're getting. Again, you will need magnification because you have to be precise enough to place it back at the same orientation. Now, class 2s. Class 2s are mythical structures. They appear during exams, and then when clinical practice, they never appear. Friends, please, whenever you see a class 2, restore it. Do not go in for crowns. How is the class 2 seen? We all read in our books, it appears as an opaque spot. That is how you see under microscope. When you prepare a cavity, there is one thing which I want you to remember always. That is called as the peripheral marginal anatomy. If you have enamel in the peripheral marginal anatomy, trust me, none of your bonded restorations will fail. And to maintain that peripheral marginal anatomy, you will require magnification. Like how you see there, that's the rim of enamel which I would want whenever I am doing a class 2 restoration. It doesn't stop there. Next comes another difficult task of placing a band. Most of the time when we place the band, we don't look whether the band is nicely adapted to your seat or not. Please make sure whenever you do it, you should adapt that band to your seat. That's also very, very clear with magnification. Like I said, not necessary that you should have only microscopes, but loops will also do this. Again, what's the magnification? It should be at least 3.5 and more, but definitely less than 5x. So once the band is placed properly, then becomes your restoration. Again, invisible restorations. Where it starts, where it ends, only you will know it. Now, let's push our luck a little more in a class 2. These are all straightforward cases. How does magnification is going to do much in that? Because this is what we've been doing. Now, same opaque lesion. Prepare the cavity, but in this case, I didn't want to break the marginal ridge. So I wanted to see the extent of caries, stain it, use appropriate instruments. If you're very careful, you can use a diamond burr. If you're scared, you can use an ultrasonic tip over there to remove it. The advantages of maintaining these marginal ridges: one, the moment I build the proximal wall off, I can always remove my band. Two, my band will always adapt really well when the marginal ridge is maintained. And most of all, I will know to what extent I will have to fill the tooth structure. So with that, I remove my band off, place incremental layers of dentine composites, and finally polish it and finish it off. That well, you can get restorations under magnification. Now, another type of class 2. See, you should understand, as endodontist, there's one drawback with us. We will always work under rubber dam. One, and when we work under rubber dam, there is a very little chance for us to see the next tooth. Sometimes what happens is, after the preparation, we will realize that the next tooth is got a cavity. We have to restore it. Magnification allows you to be very, very precise. You see that cavity? That's how I used to prepare the cavity over there. I would place my composite there, place the inlay, cure it, remove the inlay, and then refix the inlay. You get such nice contacts with these procedures, and they are 100% precise in what you are doing. Let's push it some more. Not all class 2s are blessed to have a seat. Cases like this: 2 proximal cavities, seat, halfway through I have enamel, and halfway through it's dentine, and a little rim of enamel present over there. I would prefer to work under magnification. I would prefer to restore one part of the tooth first, finish off the proximal aspects, and then go to the next tooth. When we are working under tooths like this, you need first is isolation and 2 is magnification, because I don't want my restorations to fail. The only way for us to do that is to precisely understand and to adapt the composite in such a way that the proximal wall is really, really precise and it gets adapted to the tooth structure completely. And you see the proximal wall built, then incremental layering. That is how the tooth was, and that is how it is after your restoration. You can add stains to create the morphology which you want. And trust me, morphology is already there. All you have to do is look for it. And magnification helps you to look at what you're going to do. Now, we have done with class 1s, we've done with class 2s. Let's take MODs. A simple class 2 case, that is what I thought until I saw it under magnification. Then you see another cavity at the other part of the premolar. You go ahead and you prepare it as an MOD. You see that arrow over there, and there is a bit of cavity which is still left there. This caries is the reason, or will be the reason, for the restoration to fail. If you're not careful and if you do not see this, trust me, within a year or two, the patient will come back with a failing restoration. Magnification allows you to be precise at what you are doing. Now, these restorations, till now, whatever you have seen is not to be appreciated by the patient, because you will see your work, you will be very, very happy with it because you're getting the grooves, you're getting the morphology, everything. It gives you a personal satisfaction. After this, whatever you're going to see will be appreciated by the patient. Class 3s, class 4s, veneers, all these patients play an important role. The moment you do the restoration and the patient says, "My God, doc, I am not able to see where you have filled," that actually makes your day. And how? Very simple. Trick is to see what you're doing. A class 3 over there. I have removed the caries. I still see discoloration. Most of the time in anterior tooth, wherever I am restoring it, I would not prefer to have any kind of discoloration in that area. So I go ahead and I remove. Friends, what I want you to notice is, see the amount of enamel which I am leaving behind. I am stressing on this point again and again is, please respect your tooth. The moment you remove it off, there is no going back. And with bonding, enamel gives you the highest bond. Dentine doesn't give you that much amount of bonding. If your periphery is in enamel, trust me, your restorations will not fail. I leave that enamel over there and then I bevel the tooth structure. Beveling is usually done so that you merge your composites well onto the enamel surface so it doesn't become visible to yourself and to the patient. Bevel it, etch it, bond it, and layer it. And these photographs are taken under magnification. If you cannot see the margins in this, trust me, no one can figure it out. You can see the translucencies, you can see the hues, you can actually see the light pass through as though nothing has been done there. That effective is what your restorations will be when you do it under magnification. This is from the labial approach. Now let's see from the lingual approach. What should we look for when we do the same class 3s under a lingual approach? Diet, do not take off the enamel. I will repeat it till the end of my lecture so that you will always remember not to take off tooth structure. Most of the time, when we do that, we try freehand. The problem with freehand restorations are, if you're not careful, you see that ledge which is created in that area, that again plays a major role in destruction of your existing restoration. If you have a ledge like that, please use polishing strips and then take it off. Or else use a proper band, a wooden wedge, so that you minimize the amount of ledge which is formed in that area, and then you can use a polishing strip in that area and you can finish it off. That is how it is done, and that's the photograph on the labial surface. Absolutely no extensions. Nobody can figure out that you have done any kind of restoration in that area. Whenever you're doing a class 3, you should remember that when you approach from the lingual aspect, you have to replace dentine with dentine composites. Okay? You just can't take one single composite and place it over there. That's one clinical tip which I want to tell you. Now, if the class 3 becomes a little deeper, do we have to do root canals for all the tooth? No. Magnification allows you to see pinpoint exposures. You still can give a chance for the tooth to survive. And trust me, that is one good thing which you can do. Just because you know endodontics doesn't give us the right to kill all the tooth. So whenever exposures like this are there, you can always think of direct pulp capping and to restore a tooth with a proper restorative material so that you give a chance for the tooth structure to survive. Magnification plays a major role in this format. That is why I said diagnosis, treatment plan, and execution of that treatment plan. Now, most important, that's your class 4, where everybody is interested to do beautiful aesthetic restorations. I'll tell you a case like this. So what we do, we immediately take a burr, remove the composite, and then start layering it. But there are few things what you will see under magnification which you will not be able to see with your naked eye. First is how you see the tooth structures. Always look from the incisal surface, just not the labial surface. The incisal surface allows you to assess the amount of dentine which is lost. Dentine gives the color for the tooth structure. So, whenever you do anterior restorations, always measure the amount of dentine which is lost, and then you should have appropriate beveling of the tooth surface. Bevelings, what you see here is a double bevel. So you have a primary bevel and then you have a secondary bevel. Or else, sometimes you can have an infinite bevel like how we saw in that class 3 restoration. Once that is done, then we go with the index. Said and done, most of the time they'll say index, place a transparent composite, build the index. Magnification allows you to assess the amount and the thickness of the transparent composite which will blend with the proximal surface of your tooth structure. Without magnification, it is quite impossible for us to figure this out, because in a natural teeth, you will have an area of translucency followed by an area of opacity. The line or the space between these two is very, very limited. 1. 2. On the incisal aspect, you will have an area of opaqueness followed by translucency, which is again followed by opacity. So to have such a great resolution, magnification is a must. Not necessary, you should have microscopes. Loops will also do the business. See, like I have told you, you've done the index, you've done the palatal matrix, you've done, after which you've placed the dentine. And this is an interesting part. This is an interesting video where you will understand how well you can adapt the composites. The other most important part of doing an anterior restoration is just not placing the composites in sequence. How well you adapt the composite is also plays a major role. See, we all spend a lot of money on quite a lot of instruments, Teflon coated instruments, or we have our own techniques of using a bonding agent or an alcohol swab to clean. My technique is very, very simple. I use something called as a brush, a uni brush. This is from Show. They don't come back with the instrument. I am able to create the necessary architecture which I am requiring. And when you see, when I create the zone of reflection, you see that? Exactly right now, I will be able to create those zones just like that. You see that? The moment I place the composite in that area, it starts to reflect light. This is very, very important factor when we do a restorations, because patients will never come back and tell you, Doc, you have used an A2 instead of an A1. No. They will always start with the shape. And the shape is determined by these zones of reflection. So when you're careful with the zones of reflection, your restorations again becomes invisible. So we started like that. We added dentine. We created the morphology, add the final layer, finish and polish. From there to here, like I said, a layer of opacity followed by translucency, and then the composite merges very well to the tooth structure till a point where neither you nor the patient will know where it starts and where it ends. And like I said, aesthetic dentistry is never to be appreciated. If somebody appreciates your work, don't think it's good. It's actually bad. We finished with class 3s and class 4s. Now we'll go with class 5s. What's great about class 5s? One of them, if you take a study and then you realize Class 5 is one point where most of your restorations fail. Have you noticed that? And if you are in clinical practice, you will notice it quite often, that the patients don't come back because they don't realize it also. Now, when I'm preparing a class 5, we will try it in a different manner. Let's try it with lasers. When we are doing it with lasers, it removes the tactile quotient, which means you will see what you're doing, but you can never feel it. It took around a year and a half for me to figure it out. Because imagine you ask somebody to paint over in the air. It's exactly like that. What you see here is it's removing the leftover glass ionomer. See the sparks? That's exactly what it is doing. And with lasers, again, your precision is very, very high. When coupled with magnification, it actually gives excellent results. I don't have to remove a lot of tooth substance. Once this is done, your tooth will appear like this. You go ahead and then you restore it. Etch, bond, use a flow. But these are routine things. What will magnification allow you to do is what you will see in the next picture. This is how it will look. See the margins where it meets to the gingiva. It's precise. There's no gingival tear. The margins are so well placed, and failure of these restorations will not happen. When you compare it to another restoration which is done on the molar, you can actually see the margins very, very clear. So magnification helps you to do a job exactly like this. We've done with all these. Now let's look up building up a single tooth. How well can it work? Pretty good. Gingival margins have to be slightly raised and contoured. Used lasers, rubber dam, retracted it. You see the amount of difference in value. Certain part of the tooth looks whitish, certain part of the tooth looks more dark. And see the amount of striations which you have. So much of, characterization in one particular tooth. All this will be evident under microscope. It's just not placing a composite over there. You have to get all these characterizations into your restoration so that the restoration what you do goes unnoticed. Same way, use the index, build the matrix over there, restored it with composite, marked the areas with pencil, and use a single polishing system. That is how it was, and this is how it is. Even in this, under such high magnification, you are not able to see where the restoration starts, where the restoration ends. And you are also able to see the characterization which I was talking about, uniformly distributed on the tooth surface and on the restoration also. These small details is what will make you different. And this is what will make your restoration also different. And this will make your restoration completely go unnoticed. And this is what is, according to me, aesthetic dentistry. It's not just doing a full mouth laminate wherein somebody comes and says that, oh, nice laminates. It doesn't work like that in India. With magnification, how far can we push? Can we cut between incisal surfaces? Yes. Do we need to have a specialized burr for it? No. Do we have a proof for it? Oh, yes, we do. Look at this is a TR11 burr. I am working between the incisal edges where I want to remove that part of the cavity and restore it. See the precision. I am doing it precisely because I am able to see what I am doing. Minusing this, I would have just cut the incisal area, or I would have tried something else. Magnification allows you to be precise. At the same time, you save maximum amount of tooth structure. Once the preparation is done, dry it off, go ahead and restore it. Till now, I was talking about direct bonded restorations. In direct bonded restoration, there is one step which I want to show it to you because that is usually taken for granted. The step that is called bonding. Etching, we know because it's a colored gel. Bonding, we can't take it for granted. This is how exactly it will look under magnification when you are bonding. That's an etched surface. We all know etched enamel is frosty. But when you apply bonding, you should understand the bonding agent actually flows into the etched surface. And how well or how sure you are that you are able to bond all the etched surface. When you are able to see everything in high definition, you will never make a mistake. Absolutely no chance for you to make a mistake. With this, we finish off the direct restorative procedures. Now we will go to the indirect restorations. In indirect restorations, most common or most sort of restoration is laminates. And most feared restoration is also somehow laminates. Not many take it up. Why? Is it difficult? Does it require an extreme skill for you to prepare the tooth surface? Both are wrong. This actually requires a very, very minimal tooth preparation. 1. 2, you don't require a great amount of time. The fear is because of how less you are preparing. You understand right now why magnification is very, very important, because we are comfortable in preparing more tooth structure. When it comes to lesser tooth structure preparation, we are very scared because we are worried that we will cut more. But under magnification, that doesn't happen. I'll tell you how. When you use depth cutting grooves, you have to see exactly how this works. Under magnification, where you're starting and where you are finishing. In a naked eye, it is impossible for you to be this precise. You should have some amount of magnification. Even with magnification, it is difficult for us to see the depth of these grooves. So the clinical tip here, if you're doing a laminate, is to mark these grooves with a pencil. And then use an appropriate diamond point to prepare the tooth in 3 planes, which means an incisal plane, a middle plane, and the cervical plane. All this is clearly you will be able to see in magnification. This is fine because most of the time we are all good at preparing tooth surfaces. But the problem comes only at the cervical area, where you have to have a margin, and that margin has to have a restricted amount of thickness. That's a trick. Because if you're going to prepare more, you will land up indenting. And from the start of the preparation or this presentation, I've been talking about have enamel. Laminates work well with enamel. So what happens? Do we have something for that? Oh yes. Along with magnification, start using stones. Wonderful instruments which will not cut tooth surfaces like your diamonds, but at the same time will give fantastic margins. This is at 1.6 magnification, what you're seeing, and this is how the margin will look. You see there, I was close to the gingiva, but absolutely no tear to the gingival margins. That's for an upper. This is the lower incisor. Same, you can achieve it here. If you see, one tooth has a knife edge preparation, whereas the other tooth has a beautiful margin. Both are possible if you're careful, if you're able to see your preparations clearly. So and then after you etch, you will also be able to see the amount of dentine which is exposed. Why is this important for me to see? Because more the dentine exposure, lesser the longevity of your laminates. Lesser the dentine which is exposed, longer the longevity of your laminates. So everything is clear under magnification. So sometimes people will ask me, oh my God, magnification, you take very long time. I said, yes. The long time is not because of the procedure. The long time is because of you to correct your own mistakes. Every time you learn, then the time becomes shorter, shorter, and shorter. Give it a year's time, you will master your own procedure and you will be your best critic. Nobody else will be. Trust me when I'm saying it, every time I see it under magnification, I will be criticizing my own work. That is how the preparation will look. After the preparation is done, this is how the tooth will look. And once cemented, this is how your laminates will look. If you notice, I want you to really look at it carefully. You will see the margins close to the gingiva. These are supragingival margins. These are not subgingival margins. This was kept supragingival just because there was a dent, and if I go down, I will reach the dentine, which I didn't want. But even supragingival margins can be made absolutely unnoticeable. That's the power of magnification. Now, let's go for inlays. You remember this photograph? I showed it to you, the first slide. The decision was, if I'm going to look at 4x, I will think that, okay, it is a class 2. But when I increase the magnification to 1.6x, I am able to see that the caries actually extends beyond the contact area. When I start my prep, I understand that this cannot be done with a direct restoration. I have to do it with an indirect restoration. So what's the big deal? The big deal is I have to inform the patient much before starting my procedure what exactly I am intending to do, because he has all the rights to know. If I am not able to see, I can't judge whether it will be a direct restoration or an indirect restorations. Or in cases like this where multiple restorations are failing, and then I have to restore it. You see here, in all these, I have maintained the peripheral enamel margin, which is really, really important when we are doing an indirect restoration. These indirect restorations can be composites or ceramic. If you're using composites, they are good enough, they're really nice, and they do the trick at a much lesser cost. So this, what I have done is I've used something called as a ceramage. That is how it is after I finished. Beautiful contact, very nicely fitted inlays, nothing to complain about. Why to stop only an inlay for the posteriors? Why can't we use it for anteriors? Can we do composite restorations, indirect restorations for anterior tooth? Yes, why not? If you see that photograph, I have left a little bit of enamel over there, and that enamel is not backed by dentine. That doesn't mean that I have to remove that enamel, and that doesn't mean that I have to do a full crown preparation for all these teeth. No, we don't have to reduce teeth unnecessarily. Simplest way is remove the temporary filling off, close your undercuts with composite. What I did was I took the impression, sent it to the lab, asked them to do an indirect composite inlay for these. Used that, bonded it, luted it, placed it inside, did the occlusal markings, adjusted the occlusal markings, and this is your final restorations. The reason why I did this was this is far more easier. Rather than me working there, spending a lot of time, this is easy for me to get the occlusions in place. And you see that there's a very tiny margin which you're seeing, but clinically this will not be seen, because this you're seeing that margin is because of it is seen under magnification. This is all one part of the story. Now, we all know, like I said, magnification is always being equated to endodontics. And now, in endodontics, we all know the axis cavity has been shrinking in size. It's come so small that it's smaller than a stopper size. That small it has become. Even if you see in this, it's a photograph which is taken straight. Palatal canal is not visible, but the buccal canals are all visible, which means the axis is done at an angle. What is the material of choice for us to do the post-endodontic restoration? You can restore it with composites, or you can restore it with inlay. You see this after the prep, how thick the enamel is over there and how well the bonding can happen in that area. Closed it with composite, taken measurement, send it to the lab. The choice is yours, whether you want a composite inlay or you want to go with a ceramic inlay in this place. All this has been bonded restoration. Now let me talk something about restorations which are made out of metals. Due importance, those are also good, but they highly demand a perfect preparation. They are not as forgiving as your other preps. A case like this, multiple areas of caries, started removing it. Then I saw the fissure going down. I had to remove that, then prepared it. As far as metal restorations, we have to have a primary bevel, we have to have a secondary bevel. Getting a primary bevel itself is very difficult and without magnification. Secondary bevel is quite impossible. And trust me, we are all old. I am old. And as you hit 40, right, the eyesight becomes a problem. It's very difficult, very difficult. Whoever is in the age of 40 will understand what I'm trying to tell them. The younger ones, you can see a lot many things what we cannot see. Under magnification, you can be so precise that you will get your primary as well as your secondary bevel in position where you want it, so that you will send it to the lab, and when you get a gold inlay, you will get a beautiful restoration in place. These are all with how you do your direct restorations and how you do your indirect restorations. Most of the time, we sometimes land up with reattachment procedures. Every postgraduate would have done this case. It is like they will want to do this case. But I want you to see the way I am seeing the tooth structure. Most of the time, you see the tooth, you see the fragment. Okay. What you don't see is the craze lines. The craze lines which are there in the fragment, the craze lines which are there in the tooth structure. This is to be noted. Why? These are potential areas of failures. Okay? This cannot be seen if you don't have magnification. You see that? You see a huge craze line. Plus, and in this photograph, you clearly see where the pulp is, what's the amount of dentine, and where the enamel is. In this case, it's gone subgingival. So what I did was I used lasers just to take that off so that I get the periphery clear, neat, and precise. Reattach the fragment. This is immediate post-op. This is after allowing the tooth, say around 24 hours post-op. This was after hydrated. I was talking about crease lines, right? You don't see them here. That is because I have involved all those crease lines and then I have restored it completely. In magnification, you will exactly see those crease lines, and those crease lines are potential areas of failures, which we do not want to have. Then comes the moment we see a cavity like this, we immediately think root canal. No. There are much better procedures still to save the vitality of tooth. All you have to do is see for it. Use the dye, remove the caries. That's the only point where the exposure is. Why will this tooth require a root canal? You really don't have to kill the tooth structure. All you have to do is to protect the pulp and then go in with an appropriate restorative material in that area. All this is again possible only under magnification. If you're going to ask me, should I have microscope? Should everybody have a microscope? No. Like I said, 3.5 to 4x allows you a greater flexibility of seeing these areas and protecting the tooth structure. With this, I think I have covered most of the conservative procedures which we see day in and day out, and I've also made you feel the way I see the tooth structure. Now in endodontics. Endodontics is like a hierarchy, which means magnification was owned by endodontics for a very, very long time. Now I'm so happy that a lot of other specialties have taken it up. Perio, for instance, prostho, for instance. Many of my friends who are prosthodontists, periodontists are all into this field of magnification. In endodontics, what will we look? Maximum thing is to save the tooth structure. A premolar grossly distracted, yet I am able to save 1/2 of the tooth. That is because I know exactly where to go and what to remove. If not so, I would have taken the other half completely for access prep. And I exactly know where the canals are and how easy for me to find it, clean it, shape it, and obturate it. Your magnification can also help in access refinements. When we use ultrasonics like this is how exactly I see. So which means greater liberty to do whatever I want with the access prep, look for MD2s, look for additional canals, and be very, very precise so that I do not extend my access quite wide. So that's the mesio buccal canals, your palatal canal. See the flow, how smooth, how neat they are. Apart from this, magnification also helps us to see how well we clean the entire root canal system. The video which you're going to see is what happens when I use lasers. This is of water or the irrigant which is placed inside the canal, which actually happens. It literally rips apart each molecule of solution over there, which in turn create or share the same amount of force on the walls of the tooth surface. Which means after using these lasers, seldom there is an amount of smear layer present there, which gives you the benefit of complete sterilization of your root canal and removal of smear layer. But with magnification, there is also a slight drawback in endodontics because magnification is a direct line of sight, which means magnification stops where the canal turns. That is why I'm telling you, Actually, magnification must be more insisted in conservative dentistry a lot before than what it has actually come for endodontics. So now this is the middle third of the canal, which means we are looking somewhere around 10 millimeters inside the canal. So I have done a down pack, and I'm pretty sure that my Gatapaka is completely filled over there. And then this is the backfill. Neat and nice. Canals are dry. Obturation is perfect. With this, my friends, like I said, we started this lecture by saying, is it necessary? It's just a shift in thought process. From is it necessary to it is necessary. And it's one's own personal choice. Like I said, necessity is the mother of all inventions. If you want to be precise, if you want to be meticulous, if you want to be 100% perfect in what you do, magnification is a must. With this, I finish my lecture. With bowed heads and folded hands, I thank all my teachers, my guide, my aunt, my parents, for making me for what I am. And a special thanks for Majumdar sir for giving me this opportunity, trusting in me that I would deliver what he is expecting. And the entire team of DCI, who has been helpful for me for the past one whole week. I thank you all, sir. Till we refocus, readjust, until we meet again, I'm telling you a goodbye.
Thank you, Dr. Mohan Kumar.
Thank you, sir.
For a wonderful presentation. Had there been a live thing, had there been the live crowd, I would have given you a standing ovation.
Thank you, sir. Thank you, sir.
Wonderful, wonderful, wonderful.
Thank you, sir. Thank you.
And, you know, this presentation has given not only to I am reading the responses of response and question answer from of different from different attendees. It also changed my vision also about the use of magnification in the restorative dentistry. That is very, you have rightly said that we can, by doing magnification, we can see what we are doing it. We can preserve the enamel, which is most critical for us for the direct restorations. We can see what we can make the good primary bevels, secondary bevels. We can also apply the matrix bend more precisely. We can also do a good gingival marginal finish. So these are very small things, but these things make a lot of difference in your clinical practice. And those who do these things, their clinical practice is much better than what we other people are doing it. But again, as you rightly said, it is where you are able to see what you are able to do, what you are able to see, that you are able, that is what you are doing it. And again, congratulate you for the excellent presentation. I also thank Dr. Majumdar sir for selecting you for this presentation. And this was the need of the hour, not only for endodontists, not for a conservative person, because conservative dentistry and endodontics is a practice being done by everyone, of all specialty people are doing this practice. So if your ultimate aim is, I have told you, we have to think of serving the humanity, giving a good quality of restoration, whether you are in Chennai, whether you are in Punjab, whether you are in Assam. So everybody has to give a good quality restoration, and we should feel proud of what we have given the restoration is, and that can only be done with magnification. Now, there are many, it's time of question hours. We have received around 593 questions so far, and I have sent you some of these questions, and we will be asking one by one the questions. The first question is about the loops, because many people cannot afford to go for the higher magnification. There are different type of loops, as you know, the diopter system, Galilin system, and the Catherian system. Which loops you prefer for undergraduates, for postgraduates, and those who are beginners?
So Galilean are the best, sir.
Okay, Galilean are the best, because many students have asked this question, that when we are starting with with this thing, why can't you use which loop should we prefer? We will prefer a Galilean system. Fine.
Yes, yes, sir.
And the second question is, what are the variables that affect the total magnification of the microscopes? I think it's a technical question, but we can always answer. You can give an answer for this.
There's a certain amount of variables, right from your eyepiece magnification to what kind of lenses the company uses, what is the coating on the lenses, and it is subjective to one other company. For example, if Labomed, I'm going to say, they have a different kind of a optical system. The Zeiss completely has a different kind of an optical system. So it is variable. So we really can't be very precise on telling that.
Okay. Another question is, how do we safely use microscope in COVID era, and what is the disinfection protocol we should follow for operating microscope?
Okay, that's a good question. See, because most of the lenses are actually coated with different chemicals, and the company doesn't actually tell you what coating they have done. They actually keep it strict to themselves. So we do not have an option of cleaning them with soap, neither with alcohol. I can share what I actually do in my clinic is I cover the entire microscope with a thin polythene sheet. The area which is exposed is only the part which is going to be the objective lens. That lens, I clean it with ozonated water. So you can get an ozone machine. You can ozonate the water. Studies have shown that ozonated water kills Covit and kills viruses, kills bacteria, everything. So I just take that water and then clean the lens surface. So nothing I'm not changing the chemical composition of the water, and water is one agent which you can actually use to clean.
The next question is, of course, why magnification is necessary for study in conservative dentistry, that you have already answered. From direct restoration, indirect restoration, you have rather is an eye opener for teacher like me also. Then another question is very good question. I think this will be put forward to our president DCI, sir. Sir, can't we use magnifying glasses for our UG third year and final year practices? I think with your presentation, we must make it mandatory for the UG and all the UGs to start with the magnification.
Yes, sir. Actually, it is better to start in second years.
Right. That is what the thing. I'll put forward this question. I request this thing for President DCI for making it necessary for student to start with the magnifications.
Actually, the entire process was sir's idea, sir.
Yeah. You can see the age difference between you and President, and still he wanted you to present because he wanted you to make all our young graduates, postgraduates, and dentists to do better in the practice. What we could not do, that we wanted our coming generations to do better. And I'm really happy that you have changed the perception of many of the young dentists. And then another question is, you have already answered what kind of loops we should use. You have said the Galilean systems are better. Fine. Then is another question is about the eye strain during the convergence of the vision of the uses of simple loops. I think diopter loops gives you more conversion. Other loops don't give conversion.
Yes, sir. True. But when
if you use the Galilean system, then there won't be any conversion because they are telescopic method.
Yes, a little less. But if you do not want that convergence, then you have no other option but to get a microscope.
Fine. And then is which bands are good for class 2 cavities? So that is not as is. Next is. They have asked the question, many students have asked the question, hello sir, does the long-term use of loops affect your eyesight?
Because it depends upon what loop you are using, and the convergent angle actually creates an amount of strain on your eyes after a particular period of time. That is why you should start with loops and slowly progress towards microscope. It does cause some amount of strain because of the convergence angle if you're not using the telescopic loops.
Now another question is same repetition, that why don't we include magnification in the basic dental college necessity? I think I'll put forward to my president. I hope he'll make it something. Next is, regarding matrix band adaptation in case of the subgingival caries restoration. How do you adapt the matrix band in the subgingival caries restoration?
Okay, you can actually do a procedure called as margin elevation.
Fine. Then they are asked the tips for restoring the class 5 cavities.
Okay, the tips for class 5 restorating cavities starts from one, the type of restorative materials you use. Composites, if you're thinking of, the best materials are flowable. Glass enamelers, if you're thinking of, the best materials are resin modified glass enamelers.
And then I think 10 questions are of what burr did you use for marginal preparation for laminates? For the subgingival margin preparation.
That I don't use burrs, sir. I actually use stones. These are CN stones, which are from Shofu.
Can you please repeat?
CN1 stones, sir.
CN1 stones from Shofu. Okay.
Yeah. These are Arkansas stones, sir. Actually, they don't cut the tooth surface. They actually really polish that surface off. So the chances for us to make any mistakes at the periphery becomes very, very less.
Now, another question has been asked that by doing composites under microscope, will not that microscope light affect the curing of composites?
Oh, yes. You have filters for that. You have filters which are present in the inbuilt microscopes. These are called orange filters. So when you do it, you just change the light or you move the filter towards the orange filter side, and that doesn't actually cause any polymerization of your composites.
So, Dr. Mohan, we have received around 720 questions. I have sent around 22 questions to you. Thank you for your excellent presentation. And I'm really thrilled. Same is my thing. Our students would have been thrilled after this your presentation, and some of them have rightly written. It's one of the best webinar which we heard so far. And no, all of them are good, but because it is a clinical practice, they are doing it. We are using it, so they have said like that. But all the webinars which have been done, they are really eye-opening, really path-breaking, and they have made us learn lot many things. Now, the next webinar, and thank you, Dr. Mohan, again. And the next webinar will be on 11th October. That is the 14th webinar in the series on the same time on Sunday. And more details of the webinar will be shared with you very soon. Before I conclude the session, I would like to again announce the names of top 5 dental colleges with highest participation in previous webinar. And these are Vishnu Dental College, Bhimavaram, Andhra Pradesh; Sardar Patel Postgraduate Institute of Dental Sciences and Medical Sciences, Lucknow; Saraswati Dental College, Lucknow; Paniniya Mahavidyalaya Institute of Dental Sciences and Research Center, Hyderabad; and St. Joseph Dental College, Eluru, Andhra Pradesh. We expect and appreciate the same support from other dental institutes in our future endeavor. I request all the participants to fill in the feedback form that they will receive by email along with their certificate. Please do visit the DCI website for any information and assistance related to the DCI webinar. At the end, I thank Dr. R.S. Mohan Kumar for his excellent presentation, which has not only added to our existing knowledge, but also gave us the new ideas of using magnification in our routine practice for achieving excellence in clinical outcome. This webinar has been an outstanding experience which has filled our minds with torrent of ideas, knowledge, and vision. Magnification has brought a complete change in the world of dentistry, right from diagnosis to outcome. I expect everyone to assimilate the knowledge and try to implement what they have heard. I again thank President Dental Council of India, Dr. Devandu Majumdar, for giving me the opportunity to share this platform as a moderator of this session. Thank you everyone for being wonderful audience. We'll see you next time. But before I end, I would like to pay tribute to Dr. Devdatta Das, Principal, MM Institute of Dental Sciences, Burana, on behalf of President DCI, whom we lost on 21st of this month, I, on behalf of all fraternity, dental fraternity and President Dental Council of India, pray God to give rest to the departed soul and give strength to his wife, Dr. Monica Das, and his family members to bear this irreparable loss. Thank you very much. Namaskar. Jai Hind.
Namaskar.